Hello and welcome. Thank you for joining us for these interviews that we do with the Department of Ophthalmology faculty at the University of Pittsburgh School of Medicine. I'm really pleased to have with us today Dr. Andrew Williams. Dr. Williams is an assistant professor of ophthalmology at the University of Pittsburgh School of Medicine and with the Glaucoma service. And I get to work with Dr. Williams quite a bit on some of the things that he is very interested in doing to provide, research in understanding the impact of glaucoma and other conditions in the community. So, Dr. Williams, it's great to see you, and thank you for spending some time so people can get to know you through these interviews.
Yeah, thank you so much, Lonnie. Always a pleasure to talk to you, and thank you for having me on for one of these interviews.
So you have, an amazing background. You're still very early in your career, but you're really just getting a lot of things accomplished. Tell me a little bit about your path and what led you to decide that medicine was going to be what you wanted to do, and then what's really motivated you to take on, the things that you're really involved in right now around care for your patients, obviously, who are suffering with glaucoma, but also looking at how we can really make a bigger impact in restoring or saving vision for people who are in our community and in the city of Pittsburgh and beyond.
Absolutely, and those clinical and research interests are pretty well intertwined as far as caring for patients and understanding the best way we could care for patients. So going all the way back, interest in medicine started fairly early in life. Seeing my pediatrician and having a respect for physicians and really wanting to be able to help people and understand the science of caring for others and improving the way we deliver care, and just really was drawn to that. Went on to medical school and was drawn early on to ophthalmology. I was seeing the gratification patients had, particularly after cataract surgery, just really make it an improvement in people's lives. And I also enjoyed some of the conditions that required longer term care, particularly glaucoma and conditions like macular degeneration and these other chronic eye diseases where you really build a relationship with patients over time. And I found that really rewarding and helped me to go ahead and choose that field. My interest in glaucoma deepened for a couple of reasons. First is a lot of my mentors in ophthalmology were in glaucoma. I found glaucoma were the really nice people, and that helped draw me to that division. And I also really enjoyed the work. I took a year off of medical school to spend a dedicated year of research over at the Duke Eye Center and worked with a couple of glaucoma specialists there who also worked in areas of research that I now am very interested in, health services research, or looking at the best ways to improve care. Sort of an example there at Duke, we'd recently gone on to the EPIC medical record, or electronic medical record, which was able to give patient education materials and allow a broader distribution of information about glaucoma and other eye diseases. And the glaucoma specialists there had written a number of materials, but one gap that we identified early on was, while content experts, ophthalmologists aren't always the best at necessarily writing to a patient audience, or at least some extra thought had to be taken into how to best write and communicate written materials to patients. And so our team took a step back and went to the literature, so identified a problem, went to literature to better understand how to write and how to communicate with patients, things like use of white space and active voice, focusing on really the nuts and bolts of what we're doing and why we're doing it for these different glaucoma related information pamphlets. I'm trying to stand a little bit away from the sort of basic science and complicated graphics that are interesting to us, and of course interesting to patients too, but sort of first and foremost being, what is glaucoma? Why are we treating it? And then what can you do about it? And we launched those new materials. We had patient focus groups demonstrating support for them, and also made some tweaks from patient feedback. And then we implemented that, which is still in place at Duke. When I later went back there as a fellow, it was sort of satisfying to see those still in the record from my medical student days. And then we published our outcomes showing this is something other places can do. So that sort of thought process of how best to deliver care not only drives me clinically, but also has helped to kind of guide my research interests. I came after that year off of medical school, applied ophthalmology residency, ended up here at University of Pittsburgh, which has been a really great place to train. I knew kind of early on I wanted to ultimately come back and make a career here. Went back to Duke, where I had done that research year for my glaucoma fellowship training, and then was recruited here by Dr. Sahel, and really enjoyed being part of this team. Been able to grow that health services research idea and expand it. There've been a lot of initiatives here from the leadership about addressing social determinants of health, and really thinking about the way we can make a bigger impact for our patients and for the broader community. And there's a lot of unmet need in eye care, and I think it's really important to understand the barriers patients face and the community faces to eye care, and understand how best to address those barriers. And I think kind of similar to that patient education project, similar steps and thought processes go into play, where you first identify a problem, in this case, gaps in healthcare delivery, which are widespread and have multiple components, but breaking down that problem into achievable chunks are areas that we can really address and focus in on, whether that's through direct community outreach, through these large outreach projects that you and the Eye Foundation have been instrumental in delivering, such as the Mission of Mercy Project and Dr. Waxman's Corella Eye Service, really getting out to the community to deliver care and facilitate referrals to the subspecialty center, but also getting and talking to folks, surveying patients about their needs. And another really, I think, innovative initiative from our department has been having a patient navigator, a full-time person who can help facilitate referrals and resources for patients in need. And I think there are ways we can build upon that we're actively working on. So this combination of delivering care directly, but also thinking how we can deliver care more broadly and improve the way we deliver healthcare, whether it's through improved patient education, communication, identifying needs, and providing outreach to the community. So those have been sort of like the main drivers in the health services research side of things. The last thing I'll mention is the epidemiology aspect of some of the work I've been involved in. I think there are a number of research tools we could use to help better understand and quantify some of these problems we're identifying. And one issue that has come up kind of a lot, of one thing that really struck me in my fellowship training was the problem of loss to follow-up and appointment no-show, particularly in glaucoma. It's a challenge. Glaucoma is not something, for the most part, people see or feel. And if it goes undertreated or undetected, it can lead to permanent irreversible blindness. So there's a really important communication in relationship that needs to be had with patients to understand that it is important to keep coming back, even though it's not something we can make better. It's something that at best we can stabilize, and it's important to help prevent things from getting worse. One thing I notice is there's a problem of attrition or patients being lost to follow-up over time. Based on these observations in fellowship, I led a project where we looked at our loss to follow-up rate at Duke over 10 years. We found about a third of patients were lost to follow-up, which I thought which sort of anecdotally seemed about right, but it's something that I feel like we should really talk about more. We talked about how about half of patients with glaucoma aren't even diagnosed with it, which is a huge problem in leading to screening and outreach. But of the half who've had a diagnosis, so many of them fall off, which I think is a failure of the system and in large degree on us as physicians. And so looking at that problem loss to follow-up, both at an institutional level, and then more recently, I received a grant to look at it sort of nationwide level at a number of practices, and then looking to see how we can fix it. And so that's where patient navigation and patient-centered interventions come into play. And that's another sort of series of projects we're working on. So sort of broad scale, sort of my interests, where I'm coming from with it and where I hope to see this going. And I think this is just an excellent atmosphere to be working in, because there's so much initiative from our leadership to promote patient care and improve our healthcare delivery. And that's helping not only make change, but also allow us to quantify those changes and describe a process to others to really help make a difference in a broader scale.
Yeah, thank you. And, I think this is something a lot of people maybe don't really fully understand. Conditions like glaucoma, we call them silent conditions, correct? I mean, they're conditions that you may have it and really not know until you notice, vision loss, which, as you already indicated, is not something that can be repaired or restored. So when someone who is, around glaucoma, what are the things that people need to know really about how often they should be getting checked for their glaucoma or risk of glaucoma? Is that something that's checked whenever you just go to even your yearly appointments to go and get prescription changes or other things like that? And are there ways that once you've been diagnosed as having glaucoma, is it treatable? Can we prevent that vision loss? And to what degree can we assure people that we can prevent that vision loss, for people that carry that diagnosis?
And you're hitting at exactly the big questions we have in glaucoma care. So screening and detection, and then optimizing treatment and follow-up. So as far as screening, glaucoma affects about 2% of the population over age 40. It's a big problem And like I mentioned, about half of people don't realize they have it. So for people to know, having a routine eye exam, getting your eyes checked, it's extremely important, because on these routine exams, we measure the vision, we measure the eye pressure, which is an important variable in glaucoma. You may take a look at the back of the eye, just look at the optic nerve, the cable in the back of the eye, which could be affected in glaucoma. So these routine screenings help to detect this otherwise silent disease process that can happen in the background and go undetected for some time. And once somebody has a diagnosis of glaucoma, I tell my patients, as long as we keep plugged in with each other, we can really prevent you from going blind from glaucoma. So glaucoma doesn't mean blindness. There's no reason to feel defeated by having the diagnosis. It's something that's very treatable with a number of different modalities: eye drops, laser treatments, and if needed, different surgeries to help treat glaucoma. And there's really no reason for somebody who is established with care to lose significant vision from glaucoma, because we have just so many treatments we could do to help slow it down and to help control that disease process. And I'll say, we talk about routine eye exam screenings to check for glaucoma. For somebody with a first degree relative with that diagnosis, a parent or a sibling, getting an eye exam by the time you turn 40 is I think really important, and even sooner, depending on when the relatives are diagnosed. As we know, it's not perfectly genetic disease, but there's a strong genetic component. And just getting checked, even if it's a regular glasses check or routine eye screening, we get a good idea of what's going on, just to see, could there be any suggestion of glaucoma. It can be tricky to diagnose, but we can get a good sense as long as people are getting plugged in for routine care, which is something I feel passionate about, is getting eye care to folks. And if not just for a dedicated glaucoma screening, for that comprehensive eye exam that could detect early signs of disease like glaucoma or macular degeneration or cataract. And these routine eye screenings go a long way.
Well, obviously prevention's the, and I think it's Ben Franklin said, announced prevention's worth a pound of cure. And, I think that one thing with glaucoma, we have very good ways to prevent it from advancing to where people have vision loss. What can you tell us, or do you have hope for on the horizon in terms of new treatments, or maybe ways to help people that have had some vision loss due to glaucoma that you see that may be on the horizon that's very promising?
Yeah, absolutely. And it's a really exciting time to be in the caring for patients with glaucoma, because the number of treatments is really expanded over the last 10 years. There's a lot more minimally invasive surgical options, where previously there were several bigger surgeries that could be done, had certain risk profiles, and now there's a whole space of new, more minimally invasive surgeries for those who have more moderate disease, and it just really expands our armamentarium for treatment. There's also more use of office-based procedures, whether that's a laser procedure to lower eye pressure in the office to help reduce the number of eye drops someone would have to take, or even replace an eye drop. And there's a growing space of injectable type treatments, where an injection every several months in the office may be a treatment in place of eye drops for those who have trouble taking them, and a way to avoid having to do surgery if possible. As far as restoring vision from glaucoma, it's also an exciting area, much more in its infancy, but there's been a lot of work on neuroprotection and neuroregeneration. We have a large center here at the University of Pittsburgh doing this kind of work. And it's really exciting to collaborate with our basic science colleagues on what's being done in that space. And specifically, some groups here are looking at the role of the supporting cells around neurons, the glial cells, and how those could help restore, or at least help get back some of the function from the retinal ganglion cells, or the cells that are involved in glaucoma. And so there's hope for neuroprotection on the horizon. There's even early clinical trials in development to see what we could do to help restore optic nerve function from vision that's been lost in glaucoma. So while that's on the early side, the number of treatment modalities today is just really grown, and it's really allowed us to have broader conversations with our patients about different options, and really get into how glaucoma affects their everyday life. And for some, getting off of eye drops is really important if they have regular schedules, or other things going on, or have dry eye, or conditions where it makes taking eye drops very challenging. Being able to offer other invasive options that can help sustain lower pressure to treat glaucoma in the long term has been really great. So a lot of treatment options out there on the horizon, and really, I think it's a great time to be in the glaucoma space, caring for glaucoma patients, because we can offer more now than we ever have. And I'm excited to see what happens 10 to 15, 20 years down the road.
Well, you mentioned that, when, you were in Pittsburgh before and went back to Duke, and Dr. Sal recruited you back here. What were some of the things that that you saw going on here in Pittsburgh that got you particularly excited about coming back and coming on as faculty? And obviously, we're extremely happy to have you, especially with all that you're doing and taking on in terms of helping our community here in Pittsburgh. But what are some of the things that really made you, get excited about coming back that you can see for the future here?
Oh, absolutely. I think first and foremost, the clinical care is cutting edge. The technology, the imaging, the care we're able to provide here is just wonderful. It's a privilege to be able to care for patients at a place like this. And I think the future is really limitless there, especially with the new building, new facilities, and really great minds working to help care for patients. Colleagues who are just wonderful to work with, and some folks who've really seen it all and really just are the places. It's the place to be as far as caring for patients the best possible way in glaucoma, offering a lot of resources for folks. In addition to that, the research side is just really a great culture to be in. There's Dr. Sahel and the leadership team here have worked very closely with interdisciplinary relationships with other departments and other schools, in particular, in my case, the School of Public Health here, which has a tremendous amount of resources, epidemiology research, and some of the more patient-centered approaches that I'm interested in, and to be able to form those relationships and establish that collaboration with the resources and institutional support from our leadership team has really been able to make these projects come off the ground and happen. And I feel like it's pretty unusual and very lucky for me as a new faculty member to walk in and have access to these resources to help these ideas move forward and have a lot of buy-in from the leadership team. And it's been great to be able to have this research program get off the ground and help not only care for patients in the clinics, but also establish a relationship at this university level to move these interdisciplinary collaborative projects forward. And it's really making a difference for folks. And it's kind of amazing the speed things are moving at. I wouldn't imagine a year ago being at this stage with these collaborations and having a research team the way we do here. It's been really great.
Well, I have to, agree completely because, we've seen a lot in the last year. And I think, again, it speaks well to what's happening here in Pittsburgh, but also the kind of talented people that we're recruiting here. You certainly being one of those, and we're really excited that you're here, Dr. Williams, and certainly excited that you're doing this work for our patients in the community and obviously for everybody that you care for in your glaucoma clinic. And thank you so much for filling us in on all the things that you're doing and what you're excited about. And it's been really great to spend some time with you.
Wonderful. Thank you so much for letting me talk about it. So, thanks for having me.